Thank you. I'm Adam Wilson. I am a former fellow of Professor Boileau's, and I want to thank Julie and Audrey for the opportunity to assist once again with this course, and I hope you all are taking this great opportunity to learn from two of the best in the world. I will now be giving you the surgeon's perspective on anatomic total shoulder arthroplasty. You have just heard from Audrey as well, so this will reinforce some of the points that she has made. There are three types of shoulder arthroplasty, as you all have learned today: total shoulder arthroplasty, shoulder hemiarthroplasty, and reverse shoulder arthroplasty. Today, in this talk, we will be discussing further total shoulder arthroplasty, the anatomic version. Anatomic total shoulder arthroplasty attempts to recreate native anatomy of the shoulder, but this also requires relatively normal anatomy as far as the wear that is caused by the arthritis, as well as a functioning and intact rotator cuff. When do we perform a total shoulder arthroplasty? The main pathology we do is a primary glenohumeral osteoarthritis. Again, this requires an intact and appropriately functioning rotator cuff. Without a functioning rotator cuff, the total shoulder arthroplasty implant will not remain centered within the glenoid and will not function appropriately with elevation, abduction. Essentially, you give a patient a non-functioning shoulder if you were to perform a total shoulder arthroplasty with a torn rotator cuff. In the past, a well-centered glenoid wear has been an important portion of this. Newer implants have made this less strict with some augmented glenoids. Humeral head osteonecrosis is a different pathology, which we do also perform a total shoulder arthroplasty for. Why is a rotator cuff important? This maintains a well-centered humeral head. As you can see over here, the rotator cuff provides both a downward force to counteract the deltoid, as well as a medial force to compress the humeral head within the glenoid and keep the humeral head well centered. It helps initiate motion, which is important for a normal functioning shoulder. It also prevents superior migration. As you see below, if there's not an intact rotator cuff, the humeral head wishes to sublux out of the glenoid. In this case, you would need to perform a reverse shoulder arthroplasty. Conservative options that we can do before proceeding with a total shoulder: anti-inflammatories, physical therapy for strengthening activity modification, as well as corticosteroid injections, either subacromial or glenohumeral. All these give patients options to try to manage their pain and function before they are ready to proceed with a total shoulder arthroplasty. On to the surgery. The surgical approach we typically use is the deltopectoral approach. You can see the incision here from the coracoid laterally and inferiorly. We then find the interval between the deltoid and the pectoralis major. This is open to expose the anterior aspect of the shoulder, including the long head of the biceps and the subscapularis tendon. Next is lesser tuberosity and subscapularis management. This is one of the most important portions of the case, as the total shoulder arthroplasty will only function with an intact and functioning subscapularis. There's multiple ways of doing this. My preferred way is a version of the lesser tuberosity osteotomy. However, I only take a wafer osteotomy, a very thin piece of bone or small chips of bone, as opposed to a full osteotomy, as what you see pictured. You don't want to compromise the anterior support for your prosthesis. You can also perform a tendon peel, a tenotomy, which can be done in different ways, as well as there is a technique of subscapularis sparing exposure to the shoulder. Next, we perform capsular release to expose the humerus. This is important for dislocation and exposure of the humerus. We need to release the capsule to the 6 or 7 o'clock position inferiorly, and it is important to preserve rotator cuff attachments while you are doing this. Next is the humeral osteotomy. We want this to recreate the patient's native anatomy. Many of us do this using a freehand technique. And prior to doing this with the Bovie or electrocautery, you can mark the 12 o'clock, 9 o'clock, and 6 o'clock positions on the humeral head. These 3 points give you the appropriate plane of your cut. You can also, there are humeral cutting guides with all systems. You can perform this using a humeral cutting guide. Again, you very much want to protect the rotator cuff insertion. If you violate the rotator cuff, then you you compromise the integrity of your shoulder arthroplasty. Glenoid exposure is next. There's a circumferential release of the labrum, as well as anterior and inferior capsular releases to allow for exposure of the glenoid. As seen in the picture on the bottom, a good glenoid exposure will give you a great look at the glenoid without difficulty. We use a number of retractors in appropriate positions for these, as you see in the other images. Glenoid preparation is next. We select the size and curvature of the glenoid first, followed by the appropriate guide based on that size and curvature. The central guide pin is placed, and we ream over this to get rid of any remaining cartilage and to remove some of the subchondral bone. We then drill our central peg. We select whichever implant we prefer. There are keeled or pegged implants. People have different preferences. The keeled may remove less bone. Some people think that the peg is a little bit stronger. Once we've selected our final implant, preparation is done. We cement our polyethylene into the glenoid. It's important that this, again, recreates the patient's anatomy, appropriate size without the implant overhanging the bone significantly, as well as without significant bone exposed on either side of the glenoid implant. Humeral preparation is next. We locate the central canal first, followed by canal sounding, which gives us a maximum size we can reach in the diaphysis of the canal. We then, in a stepwise fashion, will broach up from the smallest broach until we find the appropriate size stem. These imitate the final implant stem. Once we've done this, we select our appropriate inclination, which Audrey's talked to you about with the position in this specific implant, that you can select 3 different inclinations to best match the patient's anatomy. And then we size the humeral head. There are different humeral head options. It is important that we don't oversize the humeral head, as this can compromise the rotator cuff integrity. Again, this implant specifically has 3 different inclinations. Once you've matched the patient's anatomy with your final broach, you lock this into place, and when you remove the stem, it'll tell you which implant to select for your final implant. Additionally, there are multiple different heads that can be used, including low and high offset. These can be rotated to match position relative to the stem of the head to best recreate the anatomy. Again, you don't want this to compromise the rotator cuff insertion or the tension of the rotator cuff. Finally, the subscapularis repair, which is potentially the most important part of this procedure. I do it the same way that Audrey's shown you, that as Professor Boileau, drilling 4 holes both medially and laterally to the bicipital groove. The reason we do this is the bicipital groove is the strongest bone in the proximal humerus, which gives us good bone to repair the subscapularis too. We then place 4 knee sloops through these holes. The final implant is placed, and then the subscapularis is repaired. It's important to repair the subscapularis with the arm in neutral or slight external rotation to ensure that you don't over-tension the subscapularis when you repair it. Finally, after surgery, postoperative protocol is very important. Again, we need the rotator cuff to function well, and we need the subscapularis to heal well in order to function appropriately. I place the patients in a neutral rotation sling. I think this keeps the patients from scarring in an internal rotation and the subscapularis becoming too tight. This allows for best motion and function postoperatively. Physical therapy starts early, but we need to protect the subscapularis. So I keep my total shoulders in a sling for 6 weeks, as opposed to 3 weeks for a reverse shoulder arthroplasty. We start passive range of motion early, and in the early portion, we have no external rotation past 30 degrees. This protects the subscapularis and ultimately gives us the best function. If our subscap repair fails, then the total shoulder will fail. Thank you. I appreciate your time. And again, I hope you're taking an opportunity to learn a lot about shoulder arthroplasty as well as the shoulder as a whole.